Welcome to the Menopause Hour, your go-to source for answers to your burning menopause questions, the ones you won't get from your OBGYN. Brought to you by Winona, where menopause care is made easy. Download our free Winona community app where thousands of women connect and access exclusive content, expert-led courses, exciting events, and more. It's time to take the guesswork out of your hormonal journey.
Hello, everyone, and welcome to another one of our I guess not a doctor dialogue tonight, but it's a live doctor Q&A. We're so glad that you're here. Thanks so much for making the time to be here and jumping on. I know that you all have pretty busy schedules, so glad that you all were able to be here tonight. We're going to get to all your questions in just a minute, and we'll kind of let a couple more people jump in as we're getting started as well. But you can kind of see at the bottom of your screen, there's a chat button. If you've never been to one of these before, you can click on the chat button and you can go ahead and type any question that you have in the chat there. And we will get to as many questions as we're able to during this hour. So usually it does get a little bit full pretty quickly up in there. So I'd recommend going ahead and putting your questions in the chat now. But as you can see, we have our amazing Dr. Green here with us tonight, which is super exciting. It's been a little while since we've had him on one of the live Q&As, so I'm excited to have him back. It's always a great time getting to talk to Dr. Green. But Dr. Green, I will kind of pass it off to you real quick to introduce yourself, say hi, and I know there's a few things you wanted to talk about while people are getting their questions in the chat.
So hi, my name's Mike Green. I am an OBGYN. I actually did a family practice residency first, and then I realized I didn't really like taking care of sick people. But I fell in love with women's health, obstetrics, and did that full scale for 17 years. And then sort of became an OB hospitalist. And then Winona kind of took over my life. And now I'm pretty much doing this full time. So we started Winona with the idea that unfortunately, the access to hormone replacement therapy for women can be pretty spotty. There's sort of this long history of misunderstanding, not just among the lay people, but among the doctors as well. And so doctors tend to be hesitant to prescribe it inappropriately. And so this is a way to get access to this really important treatment for people. And that was really kind of the concept when we launched Winona, and apparently there's a need because we're doing really well. So that's good. And we're really glad to be able to take care of you guys, particularly those that have been maybe marginalized or sort of poo-pooed by their regular doctor at, oh, that's not menopause. And they come to us and we're able to take care of them well. So really glad to have you guys. Again, because there's so much sort of weird misinformation and misunderstanding about HRT, education becomes really important. And that's always been one of our big goals is to educate people and not just sort of, okay, here's what you need, have a nice day. But, we really want you to understand what you're taking and why and how it's helping. And again, sort of demystify this and demythify it because there's a lot of myths out there too. So that's kind of what this is all about. So please put your questions in the chat. Because I'm going to run out of things to monologue about if you don't ask me some questions. I do want to talk, there's the FDA last year changed the black box warning for estrogen, which was a long time coming, and we're really excited about that. There's a new push now to try to make testosterone more available, which I think would be a great thing. So testosterone is technically a controlled substance. And so in most states, you can't really prescribe it in our type of environment. You need an in-person visit at least twice a year. It's not something that we can really do the way we do telehealth. We use DHEA, which does help quite a bit. But for some women, this testosterone can be really beneficial. So we're really hoping that change happens this year. And there's a big push for it. So keep an eye on that. Really interesting. We're sort of getting ready in case it happens so that we can bring it to you. But the DHEA does work well. So it's good to have something that does increase testosterone levels for women that need that. So anyway, that's something kind of to keep your eye on. A lot of changes afoot. Some of them are actually pretty good. And the change with HRT was really in the right direction. And we're hoping this is going to come next. So let's see, are there any questions out there?
I think there's a few people typing, so we can give them a second kind of to think through their questions if there is any more. But I know, Dr. Green, that one of the questions that we get a lot is just kind of what to expect when you're starting HRT, or kind of like what that looks like in the first 30, 60, 90 days. I know sometimes that could be helpful just to kind of go over for like the women who are listening in tonight as well.
Okay, so yeah, and particularly for those of you that aren't patients yet, so our process basically is that we ask a series of questions that are really individualized and tailored. So the questions change depending on how you answer them. It's called an online adaptive interview. It's the same way we do it in the office. So, when I take a history face-to-face, I ask a question, I get an answer, oh, that leads me down a path. And so we have programming so that we do this sort of intelligent interview to get all the information that we need to safely prescribe HRT, or to tell you, you know what, you're not really the right candidate for it. So we ask all that stuff, make sure that this is something that's going to be safe. Once we determine that it's safe, which to me is the most important thing. So that's sort of always been the thing here, is that safety, 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 safety. I mean, if I relieve your hot flashes, but I give you cancer, I haven't helped you now, have I? So that's something that we take exceedingly seriously. Probably overkill, but I'd much rather err on the side of safety. So once we determine everything's safe, then the next question is, can we help you? Because I'm not in the business of giving placebos. I don't want to prescribe a medicine unless I really think it's going to help. Now, occasionally it doesn't, but usually it does. And so that's the next question is, what's going on? And is this something that we can help with? And then if it is, we show you options, pills, patches, cream, which form of this medicine is best for your individual lifestyle. And then I made an algorithm over about the first 1,000 patients that helps, once we decide kind of how you want it, then helps make a decision of, this is what's going to work best for you. And that algorithm actually works really well. We've sort of tweaked it over the years, but it's actually quite good. And we show you then, this is the recommendation. And then you say, yeah, that sounds great. And you give us your information. That goes to the doctor. And we have, board certified doctors in every state that we operate in. So a doctor that is licensed to practice medicine in your state, that's an expert in women's health, will review the information. If everything's straightforward, they'll send a prescription to you, send you a note explaining everything. Sometimes there'll be some more information they want. There'll be a little back and forth with questioning. And then that medicine will be sent to you with instructions on how to use it. And so then you'll use the medication. And the doctors are available anytime. So if you have a question or a concern or a complication, you just send a message in and the doctor will respond to you. But if everything's going great, we kind of check in at 11 weeks. We actually call it the 10-week follow-up because, quite honestly, originally when I designed this, I thought 10 weeks would be the right spacing, but it turned out 11 weeks worked better. But that 10-week nomenclature stuck with it. But so we follow up and see how you're doing. And if everything's going well, then we continue to refill it as long as things are going well. And if not, we can tweak the medicine to try to get the best results. So that's kind of how the program works. What to expect from the medication. Unfortunately, it takes time for medications to, number one, really kind of get into your blood system and get what we call a therapeutic level, enough in you that it's actually going to help. And then once we even get the level, it kind of takes a while for it to help. So some people get some gains right away. Like some people, it's like, oh my gosh, like I feel good immediately. But for most people, it takes a while. It can take 3 or 4 weeks before you really start feeling the benefits. And then it can take longer. It can take 3 months before you get the maximum benefits. And some of the things like weight loss can take even longer. So it's a little frustrating. It can take some time. So, we all want success and we want it now. But it does take time. The unfortunate thing of all this is that if there's going to be side effects, they tend to show up really early. But those also tend to go away with time. So for some unfortunate people, they start the medicine, they get side effects, they aren't feeling benefits yet. Eventually those side effects go away and the benefits start showing up. So there has to be some patience and expectation of that process. So that's kind of what to expect. By that sort of 90-day mark, we have a pretty good idea if the dose that you're on is going to be effective for you. The algorithm purposely shoots on the low side of what I think is going to work. And the reason why is, again, it's sort of the safety issue. I'd much rather at the 11-week mark say, hey, for you to tell me, hey, I'm doing a lot better, but I could be even more better. And I say, okay, well, let's increase a little bit. Than to say, I'm miserable, I've got all these side effects. Oh, shoot, we overshot. We need to decrease the dose. So most of the time when we're adjusting, we're increasing the dose. And that's a philosophical thing. I don't want to hurt anybody. I don't want to make you miserable. I want to help you. And I'd rather take a little bit longer to get the full benefit than cause you grief. So that's kind of by design. And every now and then you have somebody that's more sensitive to the medication, and they do have side effects, and we have to back off. So that does happen. But that's sort of the process in the first 3 months of what to expect. And then once we get you on a steady dose, for most people, they're good for a long period of time. But then sometimes as the body changes, we need to adjust the dose up or down. I've had people that have been on a stable dose for a few years, and then all of a sudden symptoms start coming back. It's like, oh, it's time to tweak the dose. And that can happen. So again, we're always available to answer your questions, to make adjustments as needed. Really, we want to take really, really good care of you. And that's a big part of what we do. So do we get any questions?
We have a question from Samantha, which Samantha is wondering. She says, is it normal to have changes in your cycle even while on HRT? She says, I'm about a year into my treatment and I spot sometimes. She says, not a normal flow, but spotting.
So the answer is yes and no. HRT is really good at most of the symptoms of the menopause transition. The one sort of Achilles heel, the one thing it doesn't work really great at is to normalize cycles. So for instance, birth control pills work really well at normalizing cycles, but they do at a great cost. So the dose of hormones in birth control pills is way, way, way higher. And the philosophy of birth control pills is to completely take over the cycle. So the birth control pills shut your ovaries down and they completely take over your cycles, which is why they're able to control them so well. HRT doesn't do that. HRT works alongside your ovaries. So it adds back the hormones that your ovaries aren't able to make anymore because they're not as efficient as they were when you were younger. But that means that you're still getting these fluctuations of hormones from the ovary. We're not shutting that down. And so it can still make your cycles not be perfect. Now that's sort of the normal thing. Now, on the other hand, if you're having spotting in between periods, that's not necessarily normal, and that can be a sign of an underlying issue. Maybe you've got some inflammation on your cervix, maybe there's a polyp on your cervix or up in your uterus, or some other issue that needs to be taken care of. So if you're getting, sort of regular periods, and then you're spotting intermittently in between, that's something that you should be seen for with an exam and an ultrasound, just to make sure there isn't something there that needs to be treated. If, on the other hand, what you're experiencing is you're getting these regular bleeding episodes every month, but instead of having a sort of normal bleeding flow, it's turned into this sort of spotty thing. That's normal. And that's a normal part of the menopause transition. And it isn't a sign of a dangerous thing. So it kind of depends on what's happening with the spotting. So spotting that's happening sort of more frequently or sort of unscheduled, that's something that probably should be looked into. If instead of having your normal cycle, you're having the spotting has sort of replaced what would normally be a normal flow, that's nothing to worry about. And that's kind of a normal part of the menopause transition. And unfortunately, it's not something that HRT is probably going to help much with.
Absolutely. And we have a question from Mia next. And Mia is wondering, she says, do you need to increase dosages after a while? And does your body get used to the HRT dosage?
So sometimes you need to increase or decrease the dosage with time. And it's not because the body gets used to it or accommodates it. It's because the hormones that your body is making can change over time. So the menopause transition isn't like your ovaries don't just shut off one day. The exception to that is what we call surgical menopause. So, if I do surgery on you and I remove your ovaries shut off that day. But that's not the way it is naturally. So normally what happens is the ovaries just become less and less efficient over time, and the hormones sort of gradually decrease. And the problem is they don't sort of do it nicely necessarily. So it's not just sort of this linear gradual decrease. They kind of spike up and down, but that spiking up and down kind of goes lower and lower. And so sometimes with time, the amount of hormones that we're replacing no longer becomes enough to make up for the hormones that your ovary is making, because it's making less. And so sometimes we do have to increase a dose, but it's not because your body gets used to the hormones, it's because your body's contribution has gone down. And every once in a while, all of a sudden the ovaries will suddenly kind of, get sort of second breath, and make more. And then all of a sudden you get some side effects. We might have to back off. That's less common, but I have seen that happen from time to time as well. So it is something that sometimes needs to be adjusted. Some people not very often, some people fairly frequently. Everyone's pretty different in how their body goes through this.
Absolutely. And we have a question from Amy next. And Amy is wondering, she says, is there a reason after 3 months on HRT that I would have a full period only 4 days after my last cycle ended? She says, I'm on estrogen in the morning and progesterone at night. I accidentally missed a day a few days ago for the first time. Is this because I missed a day?
Can be. So the progesterone in particular, can force bleeding or give you extra bleeding. It's annoying, but the progesterone will punish you if you forget it. Usually it's not one dose, but it can be. Usually it's, you go away for a long weekend and you forget your medicine, and then that kind of triggers a period, which is a drag. But for some people are more sensitive, and even missing one dose can trigger bleeding. So if it happened after missing a dose, that's not something that I would be worried about, that there's a health problem. It's just sort of unfortunate that one dose triggered that. However, if this becomes a thing and you start having this unscheduled bleeding from time to time, something that you should probably get checked out. But if it happened after missing a dose, that's probably why. It's interesting. When we have younger women, say someone comes in their 20s and I haven't had a period in long time. One of the things that we do is we give them progesterone for a certain amount of time, and then we stop the progesterone, because that progesterone withdrawal is the signal to trigger a period. So that gives us information. If we can give somebody progesterone and then stop it and it triggers bleeding, it tells us that the uterus is working, there's estrogen there. It's just the hormones aren't cycling correctly. But it's that progesterone withdrawal that triggers the bleeding. And that's the same thing with the normal cycle. And so what happens is when you're on this dose of progesterone, then you forget it, the body sees that progesterone withdrawal, and that can trigger bleeding. It's annoying, but you've got to be really good about taking the progesterone, or your body's going to, make you pay for it sometimes. So that's probably what happened. But again, keep an eye and keep a bleeding calendar. And if you start having unscheduled bleeding, it's something that probably should be looked into. But if it just happened one time after forgetting your pill, that's probably what it is.
Absolutely. And our next question is from Rebecca. And Rebecca says, I haven't received my medication yet, but what are some of the side effects to look out for or to be concerned about?
So side effects to look out for, fortunately, side effects are fairly unusual. Some people do get side effects. Usually, as I said earlier, those side effects kind of happen up front. So if you're going to get side effects, you usually get them in the first few weeks to a month, and then they typically go away. So nausea can be a common side effect, especially if you're on the pills. Bloating and some water retention in the first few weeks, which is a really annoying one, because nobody wants to bloat and have water retention, have the scale go up, and their clothes don't fit well. That's a temporary thing. It gets better, but it can be pretty annoying, and that does happen to some women. Occasionally, any medicine can give people headaches. Again, that's usually temporary. So that's another side effect that we do see from time to time. If you're using the patch, sometimes people can get a sensitivity to the adhesive, the stuff that makes the patch stick to your skin. And so sometimes that can cause some skin sensitivity. Rotating the site of your patch can help decrease the risk of that. If you're one of these people that always gets, your skin gets annoyed by Band-Aids and stuff like that, the patch probably isn't the right choice for you. If that happens, we might need to switch to the cream or the pill. So that's a side effect that we do see that's sort of unique to the patch. So those are some of the not necessarily dangerous, but annoying side effects. Dangerous side effects, thankfully, are exceedingly rare. I think the one that people worry about most would be a blood clot in your leg or a blood clot that goes to your lung, but that's really, really rare. But, if you wake up one morning and, one leg is huge like an elephant and the other one's normal, that's an emergency and you need to go to the ER and be seen right away. But again, that's exceedingly rare. But that's kind of something that, that you want to watch out for. And, it's the same advice I would give you if you weren't on HRT. If you wake up that way, tomorrow before your medicine comes, go to the ER. There's something's going on. But those kind of side effects are very unusual, fortunately. So most of the time, the side effects are annoying but not dangerous. Dangerous side effects are very rare.
Absolutely. And our next question is from Mia. And Mia says, how quickly do you need to adjust treatment if you do notice side effects? And would we continue the dosage that we have until we get a new dosage, if that's the case?
So typically, we try to work through the side effects. So as I said, most of the side effects are temporary and go away. And what happens is every time you change the dose, it can cause side effects temporarily. So that the body doesn't like changes in hormone levels. And so as those blood levels are increasing, as you're starting this new medicine, the body doesn't like that movement, that change. It takes about 3-4 weeks, about 3 weeks for most people to get a nice steady blood level. But those first 3 weeks, as the blood level is climbing, the body doesn't like that. In fact, one of the things that causes most or a lot of the symptoms of menopause transition is that spiky nature of hormone release that the ovaries do. So the ovaries are trying to they're trying to be a trooper and hang in there, but they just don't have the ability. And so they'll spit out as much hormone as they can, and then they're exhausted, and then not so much hormone, and then they spit out. And it's that spitting out of hormone, that up and down levels, that's what the body doesn't like. That's what gives you the hot flashes and the night sweats and a lot of that stuff. And so when we start HRT, sometimes it can make that worse because all of a sudden the doses, the blood levels are changing and rising as we're replacing. And then when you get to about that 3-week mark for most people, things steady out and, the side effects tend to go away. So usually, if the side effects are happening at the beginning of treatment, we tell you try and hang in there because it'll go away. Sometimes if the side effect persists, then we either need to lower or increase or decrease the dose. Usually we can at least start the process with the medication you're on. So let's say you're on an estrogen pill and we decide, we need to lower that. We can tell you to use a pill splitter. They have a little score. You can cut the pills in half and take half a pill. So that's something that we sometimes do. Or for instance, for the cream, the typical dose is 2 pumps of cream. But if we need to decrease it temporarily, we can have you use 1 pump, and sometimes as a test to see if that's going to do the trick before we send you the new dose, or 3 pumps. So there's ways to play with what you have to try to get you comfortable, without having to sort of wait until the medicine gets there. And nobody likes to waste money. I know I don't. And so we try to come up with a plan so that you can use up the medicine you already have rather than throw it out. So the doctor will work with you on that, depending on what the side effect is or what the issue is. Sometimes it's going to be, reassurance, and this is not dangerous. It's annoying. It's going to get better if you can hang in there. And sometimes it's, hey, we probably need to adjust the dose. Here's what you can do while we're, to use up what you have, and we'll get you a new dose with your next refill. So we try to work with you that way.
Absolutely. And we have a question from Amy. Amy says, could a lack of estrogen be responsible for frequent UTI infections? She says, all other factors not considered. And she says, and does Winona perhaps prescribe vaginal estrogen cream to strengthen the vaginal area that is prone to infection?
So the answer is yes and yes. So yes, frequent UTIs is a common symptom of the menopause transition, mostly because of the changes in the vaginal tissues and the lower bladder tissues. So if you think about the anatomy, you basically have a 3-story house, you have the rectum, the vagina, and the bladder on top. And so the ceiling of the vagina is the floor of the bladder. And so all those tissues are interconnected. The urethra, which is the hole the urine comes out at the top of the vagina. So changes in the tissues of the vagina can certainly affect the urinary system. And so in menopause and during the menopause transition, the tissues of the vagina tend to thin out. And the reason they're very sensitive to estrogen. And so as your estrogen levels decrease, those tissues become what we call atrophic. They get thinner. And that thinness doesn't protect the urethra as well. And so bacteria can get up, and that's why you get these infections. And so if that's the cause of it, increasing your estrogen will help beef up those tissues, protect your urethra, and decrease urinary tract infections. It's a great treatment for it. For a lot of women, the systemic HRT, the pills or the patches or the body cream, can be enough to act on the vaginal tissues to get you through this. But for some people, they need a higher dose of local estrogen, and the vaginal estrogen cream works really well for that. And we do have a compounded vaginal estradiol cream that works extremely well. And that's placed topically. And the good thing about it is it works, it's really dynamite at working, at helping these bladder and vaginal symptoms. It doesn't really get absorbed to any great extent into the blood system. So it's not going to help the other symptoms of menopause. It's not going to help your hot flashes, your night sweats, and your sleep problems. And it's not going to give you the cardiovascular benefits and the bone benefits that systemic HRT. So we usually do it in addition to your regular HRT to give you that extra benefit of the bladder and vaginal benefits that you're needing, but without losing all the other benefits that a systemic treatment is using. So if that's something that you're experiencing, message your Winona doctor and ask them about a vaginal estrogen cream. And it sounds like, that would be a great treatment for you.
Awesome. Well, it looks like that is all the questions that we've got tonight. But Dr. Green, do you have anything that you kind of want to leave the women with, something that they should know kind of as we're wrapping up?
So yeah, a Q&A doesn't go by, and this is the first one, I can't remember how long, where somebody asked me about testing. It's like, how can you prescribe me hormone replacement therapy without testing first? And so I want to talk about that, because again, this is one of these areas where there's just a ton of misunderstanding. HRT is not initiated or adjusted based on any kind of lab test, whether that's a blood test or a saliva test or a urine test. It's just not helpful. We really base it on your symptoms. Your body is the most sensitive assay we have, much more sensitive than anything we have in the lab. And not only that, even if we had something that was accurate, it's accurate for one moment in time when we do the test, but the levels are all over the place throughout the day, throughout the week, hour to hour. And so it's just not a helpful number. And this is something I feel fairly passionate about, because what happens is we get a lot of patients that went to their doctor did blood tests, the blood test came back normal, and they said, oh, this isn't your hormones. And actually it was their hormones. And then they make their way to us, we get them treated, they feel great. And it turns out HRT is what they really needed, even though their blood tests were abnormal. Or you have somebody who's on a steady dose of HRT, they're feeling great. Somebody does a blood test, oh, your levels are bad. And then they want us to adjust their medicine. It's like, well, how are you feeling? Are your symptoms under control? Oh, I feel great. Are you having any side effects? No. It's like, well, we don't want to change anything then. So these blood tests just aren't helpful. So why do people order them? And there's really two reasons. And I think the vast majority of tests that are ordered in good faith by docs that really, don't know better. So your family doc. So I was boarded in family practice. So and I can tell you that's a really hard field, because you got to know stuff about everything. But you can't possibly be an expert in all things. And so they're like, I can't help you with your high blood pressure, your diabetes, or your stuff that I have to look up on the internet that I've never heard of before that your family doctor is helping you with. But it's when I do one thing, and so it's really easy to know kind of as much as you can about that one thing. But But your family doc wants to help. They get the lab sheet and they say, oh, there's a female hormone panel on that. Let's check that and see if that's the problem. It turns out, though, that then they get these numbers and, the truth is they're not really helpful. Quest makes a bunch of money off of that, so they're happy to offer those. The family doc's not making money off it. They're just trying to do the right thing, but they just aren't educated enough to know that that's not going to be a helpful lab. And so that's why most of these lab tests are done. Unfortunately, there's a very small percentage, and it's always 3% of the population that's screwed up for everybody else, right? So there's a small percent of people out there that are sort of charlatans, and they own the lab or they get kickbacks from the lab, and they're running up the bill, and ordering all these expensive tests or doing all these expensive tests. I think that's the vast minority of people. I think most people are really looking out for doing the best they can, but that does also happen sometimes. And so lab tests just aren't useful. They're a waste of your time because they're a pain in the neck, and a waste of your money because it can be expensive, and they're just not helpful for us for hormone replacement therapy. Now, if we get to the point where we offer testosterone, that's actually a different beast, and testosterone is actually useful to chase levels, but estrogen, progesterone, FSH, LH, just really no need to ever check those things. And so, resist the urge. When you get bad information and you make a decision based on that bad information, guess what? You just made a bad decision. So information is great when it's good information, but bad information is actually worse than no information at all. And that's what I always said. I'd rather have no data than bad data, because bad data is going to lead me astray. At least with no data, I know I've got to look somewhere else. So that's really the way HRT is done. If you look up ACOG, which is American College of Obstetrics and Gynecology, the Menopause Society, they have a statement that basically just says what I just said, which is there's really no reason to do lab tests. So that's really the standard of care by all the major organizations. But this sort of gets out there and it gets done. So, don't go seeking out lab tests. It's not going to be helpful, and you're just sort of spinning your wheels. And I hate to see people wasting their precious time and precious money. So it's not useful. I like to make an analogy. I have high blood pressure, so I'm on medicines so I can live longer and keep my blood pressure under control. But I'm on a beta blocker. Nobody's ever checked my beta blocker levels and adjusted my beta blocker. They look at the symptom, which is blood pressure. Is it controlling my blood pressure? And that's the way HRT is done. We don't check the levels of the drug or of the hormone. We check your symptoms. Is it working? And that's really, really what we need to know is this working? And the right dose is the dose that relieves your symptoms without giving you side effects. That's how we know we've nailed it. And when we're in that situation, be happy. That's good.
Well, thank you so much, Dr. Green, also for going into, I know, all that with the testing. I think that's such an important aspect kind of to touch on for a little bit. And I liked your point too about the beta blocker. I think that's kind of a new great way of looking at it. So I think that really kind of helps put it in perspective. But thank you everyone who was able to be here tonight. And I also just want to remind you that if you ever have questions like these that came up tonight, and you're a Winona patient, your doctor is available 24/7 in your patient portal. Please reach out to them there. They would love to hear from you. They would love to answer your questions. That's a great resource for you to reach out to. We also have our podcast, the Menopause Hour, and that is with, it has Dr. Green on it, it has Dr. Kat on it, and sometimes we have special guests as well. So please definitely listen to that. That is a great one to kind of put on while you're in the gym, while you're driving to work, maybe while you're cooking dinner. That's kind of just an easy one to throw on in the background and listen to for a little while. But we hope that we'll be able to see you at another one of these coming up. We have one in another 2 weeks, so I hope that we'll get to see you there. I love to get to see some repeat faces. I always think that's so special and such a cool part just of the Winona community. But also, Dr. Green, thank you so much for your time. I know you've got a crazy schedule with all that you're working on, so it's always such a delight to get to see you. And I know that everyone so appreciates your time and your expertise as well. But I hope that everyone has a wonderful night. And thank you again, everyone, for being here.
Thanks for coming, you guys. Really, really fun to answer your questions.
Absolutely. All right. Good night, all.
Thanks for spending time with us. We hope today's conversation helped you feel more informed, more supported, and a lot less alone. If you're ready to go deeper, download the Winona app. It's free, it's for you, and it's filled with resources, real stories, expert insights, and a vibrant space to connect with women navigating the same season. Have questions? Join our next live Q&A. Until next time, take care of yourself. We'll be here when you're ready for more.